We're at the 25th CROI. We're here with Wendy Post from Johns Hopkins University in Baltimore. And we really appreciate you taking the time. We just got out of a press conference. And you're talking about plaque and coronary artery disease. And there were 3 presentations that covered that, which I am really concerned because that's my issue. Okay. And I think so. Set us up on what you presented.
Sure. Thank you for asking me to be interviewed today. So we were interested in looking at the associations or relationship between HIV and progression of coronary atherosclerotic plaque. We know that with effective antiretroviral therapy, people living with HIV are living longer, and cardiovascular disease is now a leading cause of morbidity and mortality. And we studied the association between HIV and plaque progression in the multi-center AIDS cohort study, or MAX. And MAX is a observational cohort study that's been following uninfected and infected HIV men. They're all men who have sex with men, and they come in every 6 months to get research examinations. And so we performed coronary CT angiography, which is a way to be able to visualize the atherosclerotic plaque. And we had 555 men who had 2 CT scans, and we were able to then measure the volume of the atherosclerotic plaque and look at differences by HIV serostatus.
So you found that the people who were HIV positive were what percentage more likely to have this plaque?
Well, we compared the third tertile of progression with the first tertile and the likelihood of being in that third tertile. And so the HIV-infected individuals, the non-Black HIV-infected individuals had a 2-fold increase in the likelihood of being in that highest tertile.
And the Black had no difference?
And the Black really had no difference, except for calcified plaque.
Any idea on what that could be? I mean,
yeah, you know, we've seen this in other studies. In the multi-ethnic study of atherosclerosis, or MESA, we do non-contrast CT scans, so we could only look at calcification. And the Blacks have less calcification than the whites. And it's not really completely understood, but might have to do with genetic susceptibilities or behavioral differences, environmental factors. We're not
because that's what I was going to
sure.
say. I think that I don't mean to suggest there's that much difference in stress, but stress seems to be pretty high. Also inactivity. I wonder if that has anything to do with it, because level of exercise versus inactivity, complete inactivity.
Yeah.
Because people that are HIV positive, I'm not saying that all of them do, but they become more relaxed, more sedentary, and that would definitely contribute to that.
So a sedentary lifestyle increases the risk for cardiovascular disease, and I don't know whether there's a difference between our Black and non-Black men as to their sedentary lifestyles, but we do know that it's important to get up and move. And
could be to figure that out, because I know I'm pretty busy. When I don't exercise, I go downhill really quick. I'm 72, or will be 72.
Yeah.
So it seems like something for me that I have to know, that I have to push myself into that. And I don't know whether there's any difference between Black people living with HIV and white people,
right,
or white men or whatever, because it seems like it wouldn't be. But anyway.
So it's important to be active, and one way to measure that is to get a monitor that measures your step count and try to aim for 10,000 steps a day. And so even at this meeting, you're not exercising, but I bet you got 10,000 steps.
No, not really, because
No?
I am right now in a wheelchair.
Oh,
so,
you are? Okay.
Yeah, so I'm thinking, this may be a challenge for me.
Right.
But if you, I'm just putting that out there.
Sure.
Okay, so it's just. So any other observations that you from this study, or
well,
from the cohort?
Yeah, traditional cardiovascular risk factors were also related to progression of atherosclerosis. So, you know, it's important smoking especially is really important to try to modify that, because smoking increases the risk for cardiovascular disease and then a number of other comorbidities. And so if we can get our patients to stop smoking, that'd be a very potentially effective way to reduce risk. But also, you know, recognizing and treating traditional cardiovascular risk factors, and that's important as well.
Gotcha. Well, I really appreciate your. Do you have any other before I let you go? I don't know if there's anything else you want to throw. Because I know that this is something that these are things that we know.
Sure.
Okay. And when you can prove them out and you can do a cohort,
right,
pull up the data, it's there.
Yeah.
That's the evidence we need, and folks, there's no question anymore. This is serious business.
Yes.
Don't smoke, exercise, and be white. No, be black. Be black. Be black. Because 50%, okay, no, you can't change that. One thing you can't change is ethnicity. But no, it's really important, I think,
Yes.
and I'm hopeful that you will continue to follow the data.
Absolutely. Well, thank you
Thank
for
you so
speaking
much,
with me today.
Thank you very much, Wendy.
All right.
Yeah.